Hello everyone, this is a 67-year-old female with chronic GERD symptoms and chronic anemia that was diagnosed with a Cameron's ulcer, a large sliding Hiatal type 3 hernia, and an hourglass stomach. I ordered this CT scan that confirmed that it was a type 3 Hiatal hernia, and her preoperative workup that I perform in every single patient that I'm going to do hiatoplasty or a surgery of this type that doesn't contraindicate the surgery. I usually put my ports as you saw. I retract the liver with the DIMA stitch, and now we're going to start the surgery. The first thing to do is to identify the sac of the sliding hernia, incise it as you can see, and identify the right cross of the hiatus. Taking in mind that in order to be able to reduce the content of this type of hernia, as in any kind of hernia, the sac needs to be dissected. I usually do this type of surgery with three arms of the robot. I manage my camera, the vessel sealer, and the fenestrated bipolar. And I like to have my bedside assistant to do the traction that I need in the patient. Doing this, I don't need to put an accessory port to introduce the gauzes or the stitches that I'm going to use during the surgery. So as in any hiatal hernia, the first thing to do is to dissect and identify the esophagus. In this case, is a little bit harder because of the large sac that is in this type of hernia. So I'm trying to connect the left side with the right side of the sac, identifying the left coast of the hiatus. First, identifying or connecting where I believe is easier, that is in the upper side or anterior part of the esophagus. Taking a lot of care and trying not to create a pleural breach, which are common during this type of surgeries. A particular advantage of doing this surgery with the robot is that I am able to handle the camera by myself, thus looking what I am trying to look in an easier way than when doing it with a conventional laparoscopic approach. Here you can see there are an enlargement of the pleura that is attached to the sac. So when I was doing my dissection, I confused this part of the pleura with the sac. So we perform a valsalva and then close the pleural bridge with my left hand, introduces this absorbable trio bilock, and then close it with one hand. This is something that can be done with the laparoscopic approach, but it is a lot easier to do with the robot due to the facilities that the movement of and control of the stitch is allowed with the instruments. I'm going to close the pleural bridge, and then to think in something else, I'm going to start my dissection in the other side. When we saw the pleural bridge, I told my anesthesiologist what just had happened. So he will be monitoring closer the patient, and we resolve it by doing the Valsalva maneuver. So I start my dissection again through the right side of the patient. I am trying to create my retro or posterior window of the esophagus. As you can see, I will introduce my gauze, and then I'm going to open the large sac that is in the left side of the patient. I'm going to trying to find first the left cause of the hiatus, and then identify the gauze that I left to complete my posterior window. This maneuver is important because it allows first to introduce what we can use to do the traction of the esophagus and the stomach. And second, it also allowed us to identify easier where the esophagus and the stomach are. So as you can see, we finally reached that point of the dissection, and now it's easier for us to do the traction of the esophagus, and we're going to continue our dissection trying to accomplish of at least 3 to 4 centimeters of intra-abdominal esophagus. Even though it is supposed at this point to be easier, the dissection, I was, especially in the left side of the patient, really careful to avoid another pleural injury. So I'm trying to dissect the sac of the esophagus. There are the dense addition of the pleura to the pseudosac, to the sac, sorry, and the esophagus. So I'm doing my dissection where I believe is the addition of the sac to the esophagus, and pulling away what I believe is the pleura. By rapidly management the management of the pleural bridge, the patient did not have any symptoms during the surgery. She did develop some atelectasias after the surgery that were managed by pulmonary exercises. She's now doing well without need of oxygen, and she had good blood oxygenation. So now that I have dissected my esophagus, I'm going to take away the sac that is obscuring my visualization of the stomach, the esophagus, and the esophagogastric junction. And now it's easy for me to identify the structures. I'm going to do the shoeshine maneuver, and this sign that I like to call the inverted P, or as an interrogation sign. And now I'm going to close the Yarus. I use pledges. The measure that I use is Stratafix. It's an observable, sorry, not the Stratafix, it's Phasix ST. Just some pledges at each side of the Yarus. And we'll close this large defect with number O, non-absorbable B-lock. I usually use this suture when the hiatal defectus are large, as in this patient. careful must be taken to first have the adequate size of the and length of the mesh of these pledges, and then put it in the right position just to reinforce the closure. I will grab mesh, then the left cos, then the right cos, and then mesh again. I will do it all the way up. In a continuous method, it is supposed to distribute the tension of the suture, even though there is always going to be tension when closing the diaphragm. I don't use a boogie, and then run it back to lock the suture. I am happy with the closure, and now I'm going to do my 360 fundoplication. I usually use two non-absorbable suture, Etibond, 3 stitches, and in this particular case I fixated the stomach to a gastropexy. Now I am happy with the result. The patient went home next day and she is asymptomatic.